Hi, everyone. I'm so excited that I have this opportunity to share this exciting moment with you all. I'm Dr. Alice Kam. I'm a physiatrist, physical medicine and rehab. I'm from Canada. I'd like to share with you this Toronto and Ukraine collaboration. We're trying to improve on concussion education / mild traumatic brain injury. So when we first started this project, we tried to collaborate with everyone, including family medicine, as well as surgical team. Now, when we're looking at the overall goal for what we're doing, we really want to maximize the education impact for Ukraine. So what's the benefits? We really want to improve on concussion education, mild traumatic brain injury for the Ukraine physicians and subsequently to the patients, improving on teaching capacity, teaching resources, utilization, also kind of creating a mechanism to allow ongoing curriculum development. Now, from Toronto side, we always try to improve and trying to really have an impact to you all and improving on medical education and patient care. Now, how this curriculum look like in Canada is that we started with a self-study guide, subsequent academic half-day, clinical rotation, and then we have our learners teaching back. Really want to improve at every single step, trying to be innovative and getting timely feedback. Really trying to use a framework, trying to co-create with the learners. Thank you very much, and I'm looking forward to meeting you all. I would like to share with you a YouTube video that I created for Ethiopia last year. It does have 2 cases, and I hope that you all enjoy it, and please do give me feedback. Looking forward to see you. Bye.
Okay, excellent. All right, welcome to our presentation on concussions. My name's Aisha Hussein. I'm presenting with Dr. Alice Kam. I do want to take a moment to recognize and acknowledge our colleague who collaborated on this presentation. Her name's Stephanie McFarland. She's an occupational therapist. Unfortunately, she can't be here today presenting for you. She has exciting news. She's on maternity leave, but she was an active collaborator for this presentation, and we'll be seeing some of her slides too.
Hi, everyone. I'm Dr. Alice Kam. I'm a physiatrist, physical medicine and rehab. I don't know if you heard of physiatry before. It's a specialty mainly focusing on managing after trauma, focusing on non-surgical management, including pharmacological and non-pharmacological management. In Canada, physiatry mainly manage brain injury, spinal cord injury, stroke, and that's how I get involved into managing a lot of brain injury related issues. I used to manage a lot of severe brain injury, managing an inpatient brain injury unit. More recently, I take on more active roles in terms of more focusing on concussion. And that's how Dr. Hussein and I connected with this concussion education workshop that we're going to deliver to you.
Thank you. And I'm Aisha Hussein. I'm a family physician in a rural area in Canada called Uxbridge. And what's interesting is that I don't have the luxury, as in big cities like Toronto, to have specialists. So we don't have any specialists in our town. And so it's really trying to manage a lot of the medicine as much as we're able to. And then if we can, we'll connect to specialists like neurologists, but it takes much longer than it is in the city. And so that's something that I wanted to share about where I practice. So for today, we're just going to do 2 cases, and it's really to emphasize persistent concussion symptoms and its management. The first one will be pediatric case that's addressing the how to manage chronic headaches. And then the second case is an adult case discussing how do we manage and approach dizziness. So for today, the learning objectives will be 3. One is to be able to manage chronic concussion symptoms through case-based learning that I've mentioned before. And we're really going to tie these in to the guidelines, and particularly for return to activities. And then lastly, be able to appreciate the contextual nature of concussion management. So let's kick off. The first case is of Ms. L. She's 17 years old. She's a competitive dancer, and she had sudden loss of consciousness at a concert for about a minute. And she comes to see you in clinic after 3 months after the injury with symptoms including headaches, dizziness, light and noise sensitivity, nausea, fatigue, and mood instability. So what we're going to do is we're going to really look at our approach to headaches. We want to be very patient-centered and really seeing and teasing out from her what is her most important and most concerning symptom. And then we'll be able to tailor that history and physical, and then the management plan according to that. So for headaches, so the first off for the history is really seeing, as you're going to manage, the quality of the headaches, and that's the adjective. Is it sharp or dull? We're looking at where's the location? Is the back of the head, the front of the head? What are the triggering factors? Is there anything that makes it better? What worsens it? So we knew some of that information from the clinical vignette. And then we're looking at how long has these headaches been for? Has it been since the injury, or did this start later? And then also looking at, for each episode of the headache, is it for a few seconds or is it lasting for hours? And then any other connecting symptoms. So she mentioned, light sensitivity, noise sensitivity. But one of the most important things is what is her functional management or functional status, so to speak. So what was she doing before? What was her functional status before this injury? And what is it now? So for instance, if she's actually doing all of the things she normally did and it's not impeding her functioning, that gives me a lot of information. And then after, because we're family physicians or we're physicians, we need to do our job. Our agenda will be to make sure we're ruling out red flags. So this is from the guidelines. It's a comprehensive list of the potential physical assessment. So we want to tailor in based on the history, really looking at the information that we want to target, the pertinent positives and pertinent negatives, to rule out conditions. So based on the information, we're going to do a neck evaluation. We want to consider doing a TMJ assessment, so putting your fingers in the ear. If she's having light sensitivity, then consideration of vision. And in this case, she also mentioned about nausea. So it's really looking at, is there diplopia that's contributing to the symptoms? And our neurological exam, so sensory and motor as well. So your history will guide you, but also we want to have a wide catchment of physical evaluation to rule out diagnoses. So let's go into management. So we have 2 broad categories, but we want to emphasize particularly for non-pharmacological management. So this means specifically you're evaluating what is her sleep and really diving deep. Typically for adolescents, it's not great in the beginning for that. So that's something that you're counseling on as well, if that's an issue. You're also looking at hydration status. What is she ensuring that she has enough protein in her breakfast, and really evaluating what is her stressors as well. And then you can contemplate about pharmacological, including tricyclics, for example, nortriptyline. So this is in the guidelines. This is here for you for your slide deck, so that way you can look at the algorithm, and it really, goes into more deep details of what I reviewed. Then we need to keep in mind what are the risk factors for persistent concussions. So there's medical versus contextual. So for instance, you can have a history of brain injury, or her past medical history can give you information that this is not going to be a straightforward case. Another factor would be if she's experiencing vestibular ocular symptoms or cognitive difficulties, that gives you and clues you in that this is going to have a prolonged concussion recovery. Contextual factors include even demographics that you can't control. For instance, female adolescents can be one of those clues that that you're going to keep in mind, that that you need to have a little bit more follow-up potentially, but you're not going to let her know because that can increase angst. The other factors are that patients who have a lower socioeconomic status, and another factor would be if they present with a lot of symptoms initially, then you know that is there a possibility of this mind-body connection, and that recovery won't be as easy because they're cluing into every little thing. So this is that information that I reviewed about medical and contextual factors, and you can review that in the slide deck. So for pediatrics specifically, as I alluded to, female adolescents, but also just keep in mind the high symptom burden in initial presentation, and also what I've alluded to as well, clinical evidence of vestibular or oculomotor dysfunction. Those are clues that would give you information that there may be prolonged recovery. Okay, so you're the only doc in this clinic and you want to have some help. So you're trying to navigate your system and trying to find that team, because the reality is you can't do it alone. Actually, this is the algorithm from the guidelines, but I'm just going to go back as well. So this is where you're tailoring that information. So you can loop into, for instance, for pediatrics, or if there's a lot of neurological symptoms, you can consider a neurologist. And so when do you refer on? So for the recovery, if the symptoms of the concussion are not improving within a month of initial presentation, then you're thinking about, is there a mind-body connection? Is there something psychological? And we call that as a yellow flag, and you're exploring that. And so that's when you loop in and start putting in that referral for extra help. So this is where it's a lot of information, but it really summarizes in the concussion guidelines that it's really the 4 weeks of the initial treatment. You're really thinking, as I mentioned, what is the medical and contextual factor that could be clouding the recovery? And then as I mentioned, you're having that closer follow-up. So is it every 2 weeks that you're going to follow up? And then, as I mentioned, what is that mind-body connection, and really addressing that. Right, so this goes into the algorithm, and you're really looking at how to get those referrals to neurology if there's neurological symptoms, and then really seeing, so for in Canada, in Toronto, there's a multidisciplinary team. It may not be available for you, and that's okay. You're really seeing who you can refer to as the next step. So I'll pass the torch to Dr. Cam, and if she has any other comments to clarify, that's okay too.
Thank you so much, Dr. Hussain. It's always excellent. So I want to take us to a second case here. Next slide. So this is the case of Mr. M. He's a 32-year-old accountant who was riding a bike on a narrow uphill pathway approximately 4 months ago when he suddenly lost balance and hit his head. He was wearing a helmet at that time. No loss of consciousness, no vomiting, no amnesia, no neck pain. Since then, has been having persistent dizziness for the past 4 months with minimal improvement. He's currently at your clinic and he's not able to tolerate return to work. On your review system, he's telling you that no chest pain, no shortness of breath, no fever or chills, no past medical history of any concussion except one that was like 10 years ago that was very remote. No other drug allergies, not taking any blood thinner. This is a very typical case of a more not so much a low income or low socioeconomic status person, an accountant, but having some persistent dizziness symptoms after a concussion. Next slide. Now, when you look into dizziness, dizziness is very similar to headaches as what Dr. Hussain mentioned earlier. You want to really take a good deep dive into the history. Your history, we really need to focus on the differential diagnosis, figure out what exactly this dizziness means, because dizziness, that terminology itself, it has different meaning to different people. And your patient may actually mean something different. And once you figure out what that dizziness means, you want to figure out how often does it happen, how long does it last, and anything make it better or worse, same as your typical history. But more importantly, we want you to focus on something called functional history. Because at 4 months after the initial injury, if they still have persistent symptoms, you want to see what the impact is in terms of the day-to-day activities. Okay, besides not be able to go back to work, how about doing kind of light housekeeping, looking after children at home? What about exercising? Going for running, jogging, that normally that he would like to do. So that functional impact would actually have a bigger impact in terms of the overall recovery itself. You think about it after any kind of trauma, if someone is not able to do things that they enjoy to do, that's a huge big impact in terms of like how they feel about themselves, and also in terms of their confidence, and also overall how they feel about their recovery. Okay, and that's how we really comes in terms of helping them out understanding what exactly is going on. Next slide. Now, this slide is similar to the slides that you saw earlier, what Dr. is saying when you guys talk about headaches. So we put everything together. Headache, dizziness, doesn't matter what kind of symptoms they're throwing at you. It's just one table, and you can pick and choose of the most typical or like most appropriate test that you want to do. We know that, in reality, you won't be able to follow this list, from top to bottom, because it's way too comprehensive. But you kind of want to pick the important one to help you to rule things in and rule things out. Because the entrance complaint is about dizziness, the vestibular portion become more important, such as the VOR exam. Okay, and next slide. Now, what I want to highlight here is something called HINT exam. Unfortunately, I won't have the time to play this video, but you have it on your slide deck. You can definitely go back. Okay, this video itself is approximately 10 minutes. It's talking a very important exam. It's called HINT exam. Okay, it helps you to kind of figure out whether this is a vestibular neuritis versus a cerebral stroke. Both are extremely important because the management is completely different, and this is not something that you want to miss. Okay, so take your time to, when you get home, trying to review it at, whenever you have a time. Next slide. Now, in this slide, we include a physical examination video. This one is more focusing on concussion itself. Okay, it's originally developed by the Buffalo team. Again, this video itself is approximately 10 minutes. I won't play the video here, but what the take-home point is that they go into a little bit more details in terms of the gait examination, okay? And such as the tandem gait, the balance test, those are really important for concussion exam, okay? On top of what Dr. Singh mentioned about the vision exam, because the vision exam is usually helping you to figure out, what's most likely that you need to rule out, right? If someone who has diplopia, for example. Now, this video is really good. Don't feel that you have to do everything. You kind of pick and choose what is most pertinent for your, for your patient, and kind of pick the test that you want to do to help yourself to figure out what exactly the diagnosis is. Concussion is a very heterogeneous disease. That means it has a mixed bag of many things in there, okay? And that's why the physics exam is absolutely important to help you to rule things in and rule things out. History is something that your patient are telling you. They may tell you symptoms that they feel. This is their perception, right? But then the physics exam is a more objective evaluation of what this perception means. So that's why it's so important. Next slide. Now, we want to spend some time talking about the management of dizziness. Okay, management of dizziness, a lot go into counseling, because the patients at the end need to figure out what exactly is going on. Okay, now common things comes common. The differential diagnosis that you want to think about, you want to rule some more most common things, such as something called BPPV, benign positional paroxysmal vertigo. Okay, that you can do the Dextopy exam to rule it out, because you need to do all this examination and also spend time in terms of doing counseling. Make sure that you slot extra time. If the typical encounter is approximately 5 or 10 minutes, trying to double it up. Okay, for myself in my clinic, I also spend more time if I know that the patient needs more time. What I do, I just tell them that next time we're going to book, double amount of the time. Unfortunately, because we have to cut short, because I have someone else waiting after you. Now, for a case in terms of dizziness after 4 months, as what I mentioned earlier, we want to talk about in terms of how they return to their activities. Okay, now because this dizziness is kind of persistent, then you want to provide the counseling in terms of helping them how they can manage this. Okay, at the end, the bottom line is that they still need to go back on doing the day-to-day activities. Even though they feel that they cannot, even though they have the dizziness, we still need to optimize them and support them whatever way that we could. Next slide. Now I want to show you a really good approach in terms of talking about return to activities. This will be applicable for any kind of activities. Okay, it's a framework approach. What we call this is a 3-point increment in terms of return to activity approach. What it is that when they initially develop symptoms, they will have a lot of symptoms. The symptoms will go up to the red zone that you see here, significant symptoms. Unfortunately, when they have significant symptoms, your patients are getting really disturbed because it's so significant. Okay, and then that kind of going ups and down, that really affect in terms of how they feel about their performance on the day-to-day activities. And that's not a good situation, because it's a negative behavior, negative feedback. So we don't want to give that negative feedback to anyone. We want to support positive behavior. Okay, so what that means is that we don't want your patients to go up to the significant symptom zone. When the moment that they hit the yellow zone, okay, then you know that the symptoms is going up, then you kind of bringing that back down. And that's why we call it 3-point increment. When the symptoms is from 0 to 3, that's in the green zone, no problem. You continue to do your activities because that's very minimum. When you're from 3 to 6, that's a yellow zone. That is still within the level of tolerance. But when you go up to beyond the 3 points, from 3 to 7 or 8, that's more than 3-point increments, then you need to tell your patient to dial back down, to stay in the yellow zone. Okay, so that's really the framework behind it in terms of pacing, and return to activities. Next slide. Now, this slide's kind of telling you that how it will look like in an optimal situation, okay? So over time, you want to increase your patient's tolerance to activities in the yellow zone, okay? And more so in the green zone that they have minimum symptoms so they can still enjoy their activities. You don't want the symptoms to be exacerbated too much so that they need to take time to take breaks so that to bring the symptoms back down to the green zone. This is the concept that will be really helpful for return to any activities. That being said, okay, you know that your patient's the best. Different patients use a different approach, okay? Some patients, you know that they're more anxious. You want to provide more reassurance. Some patients, you know that they are kind of go-getter. They do a lot for them. 60 things all happen at the same time. You kind of want to pull them back more. And when they need to do more, then you also want to think about what kind of non-pharmacological approach or what kind of pharmacological approach that you can use to help them to be successful. Because concussion itself is a symptom management. Okay, it's very different from any kind of medical disease. Because like any other medical disease, we use a certain marker as a benchmark, but concussion itself is so symptoms based. Okay, and as a physician, we're there to support them, support their recovery. Okay, now in terms of non-pharmacological management, some of the more evidence-based approach will be, you may have heard of something called vestibular rehab. Even in Canada, I don't recommend every single person who has dizziness would go to vestibular rehab. Okay, but it's something for you to think about. Okay, what that is more adaptation therapy. So over time, when they practice, first they build confidence. They also want to, at the same time, they also will adapt to the symptoms. Okay, so it doesn't matter what kind of diagnosis you kind of find that, oh my goodness, this is really helpful because they finally be able to gain that confidence back and be able to, you know, utilize the strategies that, you know, they learn from the vestibular rehab and apply into day-to-day activities. Okay, in terms of pharmacological management, it's not that many. Okay, if someone have persistent dizziness, you want to make sure that they don't have any other disease such as Meniere disease, and I expect you as a physician, you'll be able to sort this out. Okay, but if someone have other disease going on and to causing the dizziness, is there someone who has tumor causing the dizziness? That's very typical. That you know, bread and butter. That I leave it up to you. Okay, you may want to consider a consultation to a sensory specialist if you have that in your local area. Okay, I don't know exactly the resources, but I hope that this will be at least having someone, an extra person to help you, because it's very difficult to manage all the symptoms on your own. It's always a team approach. Two doctors is better than one. Next slide. Now, this one is a bigger picture in terms of how to return to activities. Okay, when you return to activities, while we're talking about that basic framework about the 3-point increments, okay, some patients that that you kind of want to take another in-depth evaluation of when something is not doing well. Okay, because it's our job to figure out why someone who cannot do certain things. For example, if someone telling you that I cannot go back to school, okay, the question is why you cannot go back to school? Is that the physical symptoms is bothering you? Is this the cognitive symptoms such as memory, attention that's bothering you? Or is that emotional disturbance that's bothering you? Potentially related to, you're anxious about going back to school, you're losing confidence, or you're not feeling that you're part of your peer group. Okay, I don't know what exactly, but that's for you to go deep, dive deep in terms of the functional history. It's really important when we talk about return to activities, we think about sleep, because sleep is kind of the basic element in terms of all human beings. If you don't sleep well, you won't have the energy to do any kind of physical exertion activities. Cognitively, it'll be very challenging for you to attend for any kind of multitasking activities. Emotionally, that's also make you more irritated. Okay, it's a concept that you need to explain to your patient. Make sure that they have adequate sleep. If they're not sleeping, you need to figure out why they're not sleeping. Okay, so if you see what we're doing it now here, it's a lot of like we use the functional approach, but then also underneath the functional approach, you need to figure out why someone is not doing something. Okay, that's more like another level. That's your physics examination will be able to help you in terms of move things in and move things out. Next slide. Now I just want to give you a summary in terms of what are the big take-home messages that we want to provide to you. We have talked about it multiple times. There's a guideline, a self-study guide that's well explained all the things that we talk about. Make sure they go back to. That's very useful guideline. Okay. Secondly, is I spend the time to provide the counseling to your patients. It may take you extra time, but when your patients understand what exactly is going on, they may not be as anxious. Okay, you actually help them for the recovery. Okay, early referral for patients who are at risk, and make sure that you always have a team behind you. Don't think that you need to work solo. Okay, and I mean, like with telemedicine, we are improving on education. I'm sure that we are also improving on providing healthcare services as well. Next slide. I want to take this opportunity to thank you everyone for joining us today. And we have our email address here, and please feel free to email us. And we'd love to get connected with you all. Next slide.
Stop here. Well, thank you so much for your attention. It was such a pleasure, and we hope to hear from you soon. All right, take care.